a detail.
Thank you for the introduction. So this is the overview of my talk. What I will do is I'll just brief you about how we have to prepare to start a CRRT and how we take off, also how we land off, and Sunil will take care of what is going to happen in the middle. We have been used for almost about 60 years or so that doing dialysis in ESRD patients is a kind of accepted norm, but there have been recent understanding that the AKI in ICU is much more than just what you call a complete renal failure. There are a lot of differences between AKI in critically ill patients and ESRD patients, what we routinely see in our what you call outpatient dialysis clinic. And the major differences have been highlighted here, and I just want to just briefly mention about few aspects. One is that there has been, even though the ESRD affects other organs like cardiac function, other things, but AKI in the ICU has a much more impact on other organs, especially the lungs and the cardiac function. And other important aspect is there is an associated confounding problems in AKI, such as hypotension, multi-organ failure, which is not seen in our ESRD patients in regular hemodialysis unit. And more importantly, there is a marked increase in the urea generation, almost to the tune of about 1.5 to 2 times higher than what we see in our regular dialysis patients. Also, the rate of rise of urea is much more higher in these AKI patients. So, the uremic burden or azotemic burden is much larger in these patients. So, we have to adjust to these factors in dialyzing these patients in AKI in critical ill patients. These are the traditional indications which we have learned from our experience in ESRD population. That is absolute indication to do dialysis where there is a threat to the life. If we don't do anything about it, the patient is likely to die. One of the important indications is a hyperkalemia if potassium more than 6.5 and it is rising, and acidemia pH of less than 7.2. I do have some issues about 7.1. I would not really wait for 7.1. 7.2 is my target in my patients, but this is what the literature says. And a pulmonary edema unresponsive to high dose of loop diuretics. I use up to about 200 to 250 milligrams of furosemide before I really say that it is not responding to high dose diuretics. And uremic complications like pericarditis, neuropathy, encephalopathy are very late. We hardly ever wait for these things to appear in our AKI patients to do dialysis, but these are all traditional indications. And more often the indications have been more softer, that where the solute removal becomes a primary factor, even not waiting for a urea of about 300 or so, or less, maybe around 200 or so, rapidly rising, I think you should intervene. And also fluid removal, it's taking a center stage in some of the units where fluid removal has been an issue, which I'll come to that a little bit later. And of course, as a regulation of acid-base balance, which is not given much importance as far as I feel. And when this is the kind of decision you make every day. You go to the ICU and you're called to say whether the patient needs dialysis or not. And before you put a patient on dialysis, you have to have a process of what you call a decision making, and you have to consider several factors which have been enumerated here. The most important is what is the nature of the renal insult, whether you know when the insult actually started and what exactly is the cause of it. For example, you know that patient had a cardiac surgery, had a hypotension during surgery, and now the patient is stabilized. Even if the patient is oligoanuric, you don't jump on him and start dialysis, because you know that things have been, insult has been a very short period of time, the patient is likely to recover, so then you wait and watch. But unfortunately, this kind of information is not available in most of our patients, where the timing and the nature of insult is not clear. In almost about 50% of cases where patient comes to you and you have a severe renal failure, you don't know when you started, a sepsis when it started, what exactly is the process, we are not entirely sure. And the second important aspect is whether the patient is oliguric or not. It is very clear that if you have a good urine output, even if it is GFR may not be good, but non-oliguric patients do very well. So you just don't have any pressing indication to do dialysis in them. However, you have to understand that oliguria or a good urine output does not reflect GFR accurately. So a patient may be having oliguria but may have a good GFR because he may be throwing all his urea and creatinine in a very concentrated manner. And you may have a large urine output, but still it could be a GFR could be low. So you don't go by just urine output alone. And one of the important factors what we look at is the change in the blood urea nitrogen or a serum creatinine. You have a normal creatinine today, tomorrow it is creatinine say about 2.5, that you know that there has been a rapid rise in the creatinine or blood urea nitrogen, indicating that patient's load of what you call nitrogenous waste products is much higher. Probably you have to be more urgent in your initiation of dialysis. And other metabolic parameters like metabolic acidosis, fluid load do have an impact. Even if you may not have a big azotemia, but you have a severe acidosis which is not getting corrected, I think you should start think about CRRT. And also you have to look at whether the AKI is just an epiphenomenon or is actually contributing. More and more literature is emerging that AKI is not a single entity. It has a major implication on systemic inflammation. So you have acute renal failure. It is not just that is what we used to say about 15 years ago when I was registered, and we used to say that nobody dies of acute kidney injury. You don't worry. You have a dialysis, but nobody dies. It's just a bystander. Is just affected, and it does not contribute to mortality. But that understanding is entirely wrong. We know that the minute the acute injury occurs, there is a systemic inflammatory response. The lungs get inflamed, and so many other organs get affected. So it is a contributing independent risk factor for mortality. So you have to think in that terms now. And other factors, these are important for our setup because financial issues are a big issue, and you know that not very many people can afford CRRT, especially if it is run in a what do you call the modern fashion with modern machine and what do you call the commercial fluids. Also, there has been some kind of a dialogue between the intensivist and the nephrologist, and if you're not very much there in the intensive care unit, the nephrologist may be called and may be demanded that, oh, please do the CRRT immediately, even though the indication may be flimsy. So the issue is, it should not be one of a confrontation, should be a dialogue, and we have to sort it out. And other issues like resource availability. You have one machine, you have two patients who require CRRT, you have to weigh the balance as to who should get the what do you call priority and that sort of thing. So you have to think about all these issues before initiating a person on CRRT. So this is taken from Mehta's what do you call analysis. This one, you have a life-threatening situation, you don't even think twice. You have a severe hyperkalemia, severe fluid overload. You don't wait for things to work. You just put a line and start dialysis straight away. And don't look at the urea, what is the what do you call other parameters, but you just straight away take it for dialysis. And if the indication is not life-threatening, that you have some time to think about, and you just look at what is the likelihood of spontaneous reversal. That is what I told. If you have an insult like a post-cardiac surgery, and now the patient is stable, you have some time that probably the patient is going to recover very soon. You don't worry much about it. You just wait, and you look at other factors also. For example, you have acidosis and fluid overload, so on and so forth. And if there is an overwhelming indication, yes, you do dialyze. If otherwise, you hold on. And if there is no likelihood of reversal, there is some soft indication to straight away start dialysis. I'm not really convinced that we should be practicing this sort of dialysis in our country. So more and more, what do you call, concept is evolving world over, saying that renal support is probably a better way to go rather than renal replacement therapy, which we generally practice. Though this works on the premises that it supports the organs, not replaces organs, and there are broad indications. There are renal, there are non-renal. For example, lung injury and so on and so forth. Burns with inflammatory response, you just start dialysis so that you don't allow the patient to get worse. And it is targeted for overall support. You don't have to wait for the replacement. You just support, try to maintain the homeostasis as close to normal as possible. And on this premise, the indications are more non-traditional, in the sense that if you have non-obstructive oliguria, urine output is less than 200 for 12 hours, that is what you call oliguria, and the patient is anuric for more than 12 hours, you don't wait for anything, just start dialysis. And the fluid removal to facilitate nutrition and organ perfusion, and this is some of the centers are very finicky about it. And more evidence, not exactly evidence, more and more people believe that cytokine manipulation in sepsis may affect. I'm not really convinced about that. And of course, coagulopathy requiring large amount of blood and there is no urine output, you just straight away dialyze the patient so that you can remove the fluid and avoid the overload on this patient. So these are all very soft indications which have not been accepted worldwide as a standard ways of dialysis, but more and more people especially larger centers who are in the forefront of research in AKI are trying to look into these factors, whether they make any difference to the outcome of these patients. So what we are looking at is earlier, in the sense that you have a low urine output, oliguria, anuria for about 12 to 24 hours, and your creatinine is not actually jammed to more than 3. And traditionally what we wait for here is somewhere here when everything is failed and you replace. So now the trend, at least in some centers, is to do dialysis earlier, so that a support rather than a replacement is the way to go. When I looked at the indications to do dialysis in my own unit, about 150 odd patients, consecutive patients who were started on dialysis, about 85% of them were on CRRT. I found there is a significant difference between what we practice and what is the best kidney practice, which is a multi-center data available worldwide over. And what the major difference was, a softer indication in Western countries, like the CRRT was initiated for immunomodulation, which we never do in our centers. And also a patient who had oligonuria for about 24 hours were started. Of course, they had other indications also. You can see that the combination is not 100%, is more than that. So we don't go for the softer indications. Most of my patients require dialysis for a severe acidosis which was not corrected, which is not a common feature in what we see in the West. And the indication to do dialysis when the urea was more than 200 was seen in only about quarter of patients, whereas it was about 50% of patients. And the fluid overload was an indication about 50%, and about hyperkalemia was very similar, about 20 to 25%. So most of my patients required CRRT for control of acidemia, to a lesser extent fluid overload, hyperkalemia, and least of it just azotemia of urea more than 200. So when do we start dialysis and what is the timing? And the question is, what is early versus late, and definition of early and late has been evolving over a period of time. And just try to go through this, what is early and what is late. This is a meta-analysis which was published very recently. Look at only 2 randomized studies and 4 prospective studies, and most of the studies were retrospective, and all this has been plotted here. So looking at this data, which it appears that it is better to start dialysis earlier, where the mortality can be reduced for almost about 50%. And a shorter duration, patients who were started on dialysis early had a shorter time to recover from RRT, so that your cost also will come down. So the trend now is to start early. The question becomes, what is this early? Early is, what is the early? If you look at all these data studies here, which again meta-analysis or a review of all the literature, the earlier studies which were the 60s and 70s, the late was, this is urea nitrogen. Urea is about 2 times higher, that is 400. So late was 400 or 450. We never wait for those kind of numbers now. And early was about, say, 300 or 150, 300 or 240. So as the time has evolved, this late and early has been changed over a period of time. And we have 2 randomized studies in the last decade or so. And if you look at these 2, numbers, where the CRRT was initiated early at a blood urea nitrogen of about 50, and late was around 100. And both the studies did not show any change in the mortality, the difference between these 2 groups, like the early versus late. So what we decipher from these studies is that there is no difference in survival when the renal replacement therapy was started between blood urea of 100 or 200. In other words, blood urea nitrogen above 60 or say about 120. So anything above 200, I think you should be very cautious to start dialysis. Between 100 to 200, I don't think you should really panic and start dialysis, because there is no difference between these 2 numbers. I have a problem with this kind of a definition, because if I look at my own data, only about 25% of patients had an indication to do dialysis when the urea was more than 200. So most often I did a dialysis not for urea but for something else. So we have to take all those factors which affect the initiation of dialysis into consideration. I looked at my own data, about 200 odd patients who were taken over a period of about 8 years. And even though the data was taken prospectively, the analysis was done retrospectively, and this kind of grouping was done again retrospectively. This kind of a retrospective analysis has its own problems, so you have to be cautious in interpreting this. So when I looked at all this indication to do dialysis, when the urine output was low, that is or anuric, that is a definite indication, probably more than 24 hours you should do a dialysis. And if you have 100 to 500 as oliguria, that is a soft indication, probably you should do. And the urine output is reasonably good, more than 500 probably you don't need. So I put them a score, definite indication, yes, maybe, or no, this is probably no. So the same kind of logic was applied to blood urea levels at the time of initiation of dialysis, less than 80, that is BUN of 80 to 120 and more than 120. And pH of normal pH, somewhat metabolic acidosis, definite metabolic acidosis. I did not have a data on the volume overload in my patients, so I could not put it, but ideally you should be putting this also. So if you look at all these three parameters, you could have a score of maximum score of 9. So if you have a 9, that means there is a very strong indication to do dialysis, probably you are starting dialysis late. So if you put them all into these groups, we could put them into two groups, so-called early dialysis where the score was lesser and late dialysis score was higher. So the number of patients are almost equal in two groups. And we looked at the mortality at 28 days in the hospital, we found there was a difference. The mortality was much higher in patients who had started dialysis later. Only about 12 out of 72 survived, whereas 30 out of 87 survived in early group. This is a univariate analysis. If you put a multivariate analysis, this kind of a difference vanished, indicating that there are probably more other factors, confounding factors, not just early and late. But my understanding over a period of last one decade has been that it is better to start dialysis earlier. But the question again comes, what is the earlier? I am a conservative man, but still I think we have to start dialysis earlier. Do not wait for the very late indications to appear to dialyze these patients. Coming to the dose of dialysis, that has been a vexing issue for a long period of time. How do we express this dose? When you talk about dose, there are two ways of expressing it. One is ml per kg per hour, which Dr. Mishra and others alluded to, and another so-called KT over V. I'll just come to that a little bit later. So what is the kind of prescription you give? It depends on what other parameters are. That is, what is the degree of azotemia to begin with. Suppose you have very high urea, maybe around 300 or 350 to begin with, the patient comes with a very high urea, you have to start with a higher dose. You don't have to start with a low dose or a standard dose. But if you have a very low urea levels and creatinine levels, the indication is more of a fluid overload. You don't have to give a very high dose of dialysis. You have to give a low dose and keep the ultrafiltration a little bit higher. Also, it is influenced by several other factors, especially the rate of catabolism, the blood urea nitrogen appearance, what we call the rate of catabolism with urea generation. Again, it is depends on age, gender, body mass, and sepsis, or what we call a SIRS. And all this issue started with about 12 years ago when Ronco published a study showing different gradations of dialysis, 20 versus 35 to 45, found that there was a significant difference in the mortality between 20 ml per kg per hour to 35. And it became a norm to give about 35 ml per kg per hour. But I never was really convinced about that. There were some issues about this study in the sense that always CVVH and the fluid replacement was post dilution, and this is not the kind of dialysis practiced in North America or elsewhere. It is a purely European, Italian way of doing it, and you know that giving a very high CVVH with a high dose of ultrafiltration, giving the fluid post dilution is likely to reduce the lifespan significantly, and it is a very labor intensive kind of dialysis, and nobody practices it. So, but they took this data from 35 ml and put it to CVVHT and started practicing all over, that is 35 should be the norm. You also found some interesting data that if you have a septic patient or hypercatabolic patients, giving even higher dose, more than 35 ml, may